Okay, I see a couple people. Looks like you've joined here. Let me know in the comments if you are here and perhaps where you're coming from and what your interest was in watching this today. And let me know if you have some questions. While you're typing that, I will just say live here, just sort of again a review of the cap as I'm watching this again. Um, uh, the reason that I gave this replay is because when I put this presentation together last week, I started realizing that, this initially started off as the focus was just substance use assessment with young people. That's sort of something I've specialized um, in forever. And as I got into putting the material together, as you just saw there, I realized that this goes into a much deeper or broader topic, and I think really important as we discuss how misconceptions, misinformation, lack of public awareness about our understanding of, watch now, I'm saying terms like addiction. I'm not even saying misunderstanding of addiction, terms like addiction, um, how these all add up to create barriers and to effective prevention and intervention efforts. And in that case study that I've been using about the 18-year-old who, was resistant initially, but he gave such a powerful example at the end. The fact that he was open-minded to what I presented to him, and he was able to say, I really liked how you changed that understanding for me, when that point about you have a problem but you're not addicted, and that softens it up so much as far as it's not threatening to them, for to say, and I suggest, you see that we should manage this. um, uh, I don't know if I said this in the presentation, but he said that he had been, um, avoiding the second floor bathroom at his school, and he had stopped going out on weekends with his friends that party. And I told him, you're treating your substance use disorder. You have a mild substance use disorder, which his therapist, and this is the thing that really chaps me, is that therapist for a year told him, and told the parents he's got a mild substance use disorder, which means it's only mild. We don't need to do anything about it. And 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 as far as developing a treatment plan, and so when I said you've been attempting to treat it yourself, that's what treating it is. Making a list of things I should, change in my lifestyle. Don't go by the second floor bathroom. Don't go out with my friends who party on weekends. And then all it takes is suggesting, can you see that maybe having a little bit more sophisticated approach to treating this, like having a professional help sort of supervise doing that. And he was fine with that. So that's one of the first points that I think is so important out of this presentation, is recognizing that a person can, quote unquote, have a problem but not be addicted. That's the dichotomy that is still stuck in people's heads, that if we haven't crossed over that line, there's not a problem. And the reason I put in the comments while we were watching them, that this was that part about the fact that what we used to consider characteristics of addiction only lived over there on the severe side. And see, notice that I say side instead of end. Even though they called it a spectrum that ranged from abuse to dependence, that wasn't really a spectrum. It was a dichotomy. one side or the other. And we used to, like I say, consider those characteristics of addiction were only over there on the severe side. And when they suggested that those characteristics can be experienced by people with mild disorders, as I said in the presentation, it took me a long time to get my head around that. And a number of other colleagues were like, wait a second, no, that doesn't make sense. If they're experiencing those things, that is addiction. That was our old way of seeing that. And when I started being able to point out and recognize for myself that, sure, I've got lots of clients that have quote unquote mild disorders, but they can perfectly well give examples of those characteristics of addiction. That's so important because, of course, as I said earlier, the parents, are hoping they haven't crossed over that line into the quote unquote addiction part, the bad part. We're hoping that we haven't gotten there. Well, I can't remember how much I emphasized this during the presentation. The only thing that's going to cause a person to progress into that more severe end of the spectrum is continuing to use. And so if we say, don't use anymore, and they say, okay, I won't use, whether they mean that or not, but we don't follow up with a quote unquote treatment plan, some plan for managing this, those characteristics of addiction rear their ugly heads. Chronic, it doesn't go away. They still have this tendency to use in a problematic way. Progressive, they continue to use more, and also the consequences related to the use can progress. That one example that I gave at the end there of the girl who was placed in the dual diagnosis PHP program, day hospital program. That meant she wasn't going to school. She went to school at that place during the day, but the day that she got back to school after completing 8 weeks of dual diagnosis treatment, she got arrested. That would be an example of her consequences progressing. Her substance use problem didn't go away just because she acknowledged that she should not use. I'm sure she said that many times during that PHP program. But they didn't manage it. They didn't put a treatment plan in place. And we see what happened, and her disorder progressed. I am going to read Stephanie's. Hello, Stephanie from Glenwood Springs, Colorado. I really appreciate details on DSM definitions. Are there any other words like addiction that are trigger words we should stay away from? Good question. Trigger words, it's I didn't go into this in the presentation, the word dependence or dependency. That actually was the first thing they identified as their reason for changing the DSM-5 is because they put a lot of emphasis on the confusion that the word dependence creates. Because here's the deal. Again, the old model, one diagnosis was substance abuse on the mild side, and the other one was substance dependence on the severe side, right? And that word dependence, that's when they started saying was a trigger, as you say, or shaming, stigma. And one of the first things that we understand, it creates so much confusion. I think, I'm not sure, Stephanie, if I know you and if you may be familiar with the Rehab Works course. Put a 1 in the chat there if you're familiar with Rehab Works. If you are, you'll may have seen in some of the videos in there that um, I have an example there where I said some parents once told me, we realize there's an addiction, but we don't think there's a chemical dependency there. And prior to that, in those videos in Rehab Works, I gave that whole history of the dependence used to, and chemical dependence, when drug treatment first started, years and years and years, really early, like we're talking the 40s and the 50s, 1940s, 1950s, the term chemical dependence did specifically refer to the physical dependence on a substance. And this is key. Not all substances cause physical dependence, right? But what happened is drug treatment evolved and became a little more sophisticated, and we grew into, the basis of what we know as treatment now. There's a couple of treatment programs in Minnesota that started all this, and so they call it the Minnesota model. Part of that evolution, the term chemical dependence morphed into the term chemical dependency, and it changed from referring specifically to the physical dependence. I'm going to get sick and have severe discomfort if I discontinue this substance. That's what happens with opiates. It's what happens with alcohol. Heavy long-term alcohol use to get to that point. The opiates are what we're familiar with because it creates dependence so quickly. So there's some other chemicals that do that. The reason this is so confusing, cannabis doesn't do that like those other substances. It's not to say that there aren't withdrawal symptoms from cannabis use, that a person, if they've been using heavily, they might experience trouble sleeping, decreased appetite, irritability. Those are kind of things, but not the same kind of violent physical symptoms that someone going through severe opiate withdrawal will experience. But as I said, we morphed from starting to refer to addiction as chemical dependency, and we called treatment chemical dependency treatment. And like when I got sober in Minnesota in the 80s, it was really common to identify ourselves as chemically dependent. And I'd say that in support meetings. Hi, my name's Jim. I'm chemically dependent. And I remember, that if you said that in a meeting today, I said it a few times. Partly when I moved away from Minnesota to Texas. And I remember I called myself, I was in some support meetings and I said, I'm Jim, I'm chemically dependent. And I didn't realize nobody else said that. And so again, the chemical dependency, we started identifying or translating as addiction itself, chemical dependency treatment, and we lost that identification with the physical dependence. And so that's, again, the parents that said, we realize there's an addiction, but we don't think there's a chemical dependency. That could have prevented them from following recommendations because they weren't seeing the physical symptoms of withdrawal. Their loved one wasn't, tweaking and shaking and going through seizures by not having their substance. So they didn't think there was a chemical dependency. And the way we're using that term chemical dependency now, or now we're not at the time, in the middle time period of what we're talking about here. I knew that this patient was quote unquote addicted. I knew that they had a substance use disorder that indicated it needed to be treated but because the family wasn't seeing the tweaking signs, and as well as that's what causes patients to not think that they're addicted. I'm not experiencing chemical dependency. So that's the big one, the words dependence or chemical dependency. I don't know. I'll think of, see if there's anything else off the top of my head that I can think of. That's the big one. Do you got anything else? Any other questions? And if there's anybody else in here that would like you, okay. Do I know you from Colorado, Stephanie? Okay. I'm going to wrap this up. If you don't have any other questions, let's see. Yes. Okay. Um, so again, all the material that I was presenting in here, this is a really good way to hear me talk about what you're learning in the Rehab Works program. For those of you who are tuning in later, Rehab Works is an online family education course that I created. And the first module of that is the information that I present in here. I happen to be really focused on the importance. I recognize the importance of comparing the old way of thinking to our current view of substance use disorder, because it helps illuminate that problem that I see us of conflating, that people think, again, the old model, there was a line you cross over. New model, if you haven't crossed over the line, it doesn't mean there isn't still a problem there. And so all that material about the DSM-4 and the DSM-5 is in my Rehab Works course. If you're not using it as with a family member in a treatment center, which is how a lot of people get introduced to Rehab Works, it is available that you can purchase it directly yourself, or you could work with me if you're looking for family coaching. That's what I specialize in, is working with families while their loved one is in treatment. Rehab Works goes a lot further into, as I said, that what we've been talking about here is just, and this is important, starting off, making sure everybody's on the same page of understanding what the problem even is that we're treating in substance use treatment. And that's what I started figuring out, is one of the biggest reasons for treatment failure is that we never, out of the starting gate, the parties involved, the client, the family, and the treatment team, all have different definitions or ideas of what it means to have a problem. And nobody's on the same page. And that literally prevents treatment from progressing, because we end up in power struggles throughout the whole treatment process. And so that's why one of the first things that I do in Rehab Works is just make sure everybody's on the same page. And the reason that I focus on working with families is because if the family understands this, then they're going to be in a position of not knowing if they're not getting the straight story from the client. Sometimes the clients might not report exactly what they're learning in treatment to the family if it's something that they don't really like or they don't agree with. And so that puts the family in a very awkward position. They end up feeling sort of crazy because you're not exactly sure what to believe. So first thing that I do is just make sure that the family understands all this about substance use disorder. But then in Rehab Works, I take that further and go into teaching the families about their role in supporting a loved one in treatment. And which includes being informed about what the client's learning in treatment, but then knowing how to take that being informed into identifying appropriate boundaries, what kind of expectations families should have when they have a loved one in treatment, what's appropriate and what's not. How about the word control? We got to do a lot of talk about control. What's within a family's control and what's not within your control. And there's a lot to talk about there. There are things that are appropriate for families to expect as far as if a loved one's in treatment, you want to make sure, or you're going to hope, and it's appropriate for you to have the expectation that they're following the treatment plan. Because if they're not following the treatment plan, that has implications for you. But then as we go further into teaching about setting boundaries, that means, you're not forcing or controlling your loved one in treatment, but you're just simply saying, if you're not following the treatment plan for addressing your substance use disorder, here's what I'm going to do to prevent myself from being drawn into the unhealthy dynamic of supporting avoidant behavior or dancing around elephants that are in the living room when we both sort of know you're not following your treatment plan. And when families start learning about their own, what we say, quote unquote, recovery, which is about how you respond to other people around you and knowing where your boundaries are, again, you're making it, a choice as opposed to, trying to control them or force them. You're just taking care of yourself, which might, like I say, include some things that encourage them, strongly encourage them to make sure they're following the treatment plan. That's all about setting boundaries. And then the third piece that I go into in my Rehab Works course is teaching families about that stages of change that I mentioned. I gave a little presentation. I said in the presentation today, this is a short form. I only introduced today the stages of change to show about where motivation fits in the treatment or recovery process. In Rehab Works, I go a lot further in using the stages of change to, one, make sure that the client is establishing a solid foundation for recovery. And then the second thing is, for families, it just is very effective in helping understand how long the treatment process takes to do it effectively, which includes understanding the continuum of care. And so, I remember when I was beta testing Rehab Works and I was getting survey responses from families. I remember, what was the best thing you got out of this course? One time somebody wrote, this was really helpful. I thought treatment was just detoxing from the substance. And I remember when I read that at first, I was like, whoa, I sometimes forget how much information families need, or the general public. They didn't even understand the difference between detox and treatment. But the point being there is that understanding treatment, it's very common for patients to think that they're further along and they're done with their treatment process way earlier than they really are in the process. And the stages of change are really effective in showing how long that treatment process and in particular, the continuum of care. It usually starts off at an intensive level and goes through a series of step downs in level of care. So lots of times patients start off in residential treatment, but then they step down into outpatient care, either PHP, which stands for Partial Hospitalization Program, or IOP, which stands for Intensive Outpatient Program. And so they might step down from residential, go into PHP for a couple of weeks. That's full day treatment, usually 5 days a week, maybe. And then after several weeks of that, they step down into IOP, which is usually maybe 3-4 days a week, much less time, 2-3 hour group sessions at a time. And they might do that for another 4 to 10 weeks in IOP. And then important is to understand continuing in some form of professional care. It doesn't have to be real intensive. Often by that time, we're ready to just start working with an individual counselor, a 1-hour session once a week. I work with clients all the time. I do aftercare for clients coming out of treatment. And lots of times we start off once a week, and then we do that for a while, and then we drop down to twice a month sessions. And then after a while, we drop down to once a month session. I have several clients, right now that I've been working with for a couple years, and I see them once every 2 months. But there's a big difference between checking in once every 2 months and not having any contact with your original counselor or with professional care, somebody who's familiar with your case. It's a totally different situation when you're out there with no professional accountability. So again, that stages of change is very effective for helping us understand the treatment process. And with that, you can see I've gotten to the opposite of where we started. This presentation today was about early intervention and assessing how do we even get them started being, open-minded about addressing the issue. And then hopefully if we do get them open-minded and moving forward in being willing to develop a treatment plan, that's then some of the stuff that's coming down the pike as far as what treatment looks like and entails as far as a long-term process. Okay. Anybody else got any other questions? I might wrap this up. Please feel free to reach out to me if you've got a loved one who's in treatment and could use some extra support. That's what I specialize in. I am all about, I ran my own IOP program for many years, as I said in our presentation today, and I saw, the tragedies that happen and how difficult it is for families to understand how to navigate this whole treatment process. And after running my own treatment program for 10 years, I decided I want to help families work to avoid the tragedy of failed treatment. And there's so much that can be done to avoid some of the inherent problems in the way our current system. Families sort of get left out of the picture, and there's a lot that you don't know about that you could be doing that's within your control that can make all the difference in the world, and the difference between a failed treatment experience and a successful treatment experience. And so I help families in that area. I have a coaching program. If that's something that you'd be interested in, find me on jimsavage.net. You can schedule a free consultation. And I'd be happy to talk to you about and see if there's anything I can do to help you. So again, I'll sign off. Thanks again so much for being here. I really appreciate it. And I hope this is very helpful for you going forward. See you later.